Hi, and welcome back to the Trusted Messenger podcast, where, in fact, let's talk about it. We haven't mentioned this yet, Todd. We are coming to you live from evidence-based studios at TMPHQ here in the great city of Pittsburgh, Pennsylvania. I am your co-host, Trusted Messenger Program VP of Comms and Strategy, Chad Herman, along with, as always, your other co-host,
Executive Director, Dr. Todd Willin. Thrilled to be here this week with you, Chad, and we have a cool guest.
We've got an outstanding guest. Let's just get right to him. As you can see on the screen, he is Dr. Cedric Jamie Rutland. He's a pulmonary critical care physician based in Southern California. More on that in a minute. And he is also, as you can see from his on-screen ID, he is a producer. He's also the creator of Medicine Deconstructed, a YouTube channel dedicated to, and this is stuff that is very near and dear to Todd's and my heart, quote, laying out a variety of medical topics for the layman, medical professional, and the like. No white coats or haughty medical terms that require a dictionary to comprehend. He's already speaking our language, Todd. Dr. Cedric Jamie Rutland, welcome to the Trusted Messenger podcast. How are you today?
I'm great. Thanks for having me. I also have the Health Exchange podcast, where we do sort of the same stuff that we do on Medicine Deconstructed.
Beautiful. Todd, you made this connection, so why don't you start us off?
Yeah, I'm going to ask Jamie to go into his origin story because I think it's just awesome because, again, Jamie, we're all about the end of the show is about tying the bow around how to make healthcare communication better. Everybody's flipping out right now. Everybody's flipping out, and we're hearing this, and I'm sure you're hearing this. Every visit takes 5 to 10 minutes longer. Quality scores are dropping in terms of immunizations, antibiotic use, and anything else. Like everything is being questioned, refused, or people are looking for some other answer. But the data still shows people trust their healthcare providers. So how we reconcile this, and the whole point of this is how do we make that connection better? If the trust is there, how do we make the communication better? So can you start with your origin story and just how do you get to being a producer to podcasts? What, shouldn't you just be in an ICU somewhere, like say saving people's lives?
I was in the ICU. I still do the ICU every month, about 3 to 5 times at night. You know, that's a very big question, interesting question. Origin story first. I had recently reconnected with some of my friends growing up in elementary school. I went to Catholic school from kindergarten to 12th grade. Holy Spirit Elementary School, 8th grade year. In the yearbook, back page of the yearbook, it says most likely to host a talk show, right? Cedric Rutland, which is really interesting, right? Because I thought nothing of it, right? Didn't think anything of it until recently. And basically what happened was this. In medical school, I barely got in. I went to University of Iowa. I was like number 105, 104 on the out-of-state wait list. All I did to get in was communicate. I called Iowa every single day. And my goal was I did not want Iowa to treat me as number 104. I wanted them to know my name. That's all I wanted. So I called them every day for about 2 weeks, and I went from number 104 to being accepted. And I remember the day I got accepted, Linda called me, who was on the financial aid team, and she said, it was a 319 area code, which is Iowa City's area code. And she called, she said, Jamie? And I was like, yes. She's like, guess what? And I was like, I'm in. And she's like, you're in. And I got into University of Iowa, right? And so then I understood the power of communication. So I start medical school. And in medical school, I wasn't the smartest kid. I just studied my butt off every single day. And I was a mechanism guy. I needed to understand the basic Legos. I needed to understand the 4-pegged Lego. I needed to understand just the bottom of the barrel. I didn't want to memorize anything. I wanted to actually understand it so that I could build on top of the concepts as I moved forward in school. And so I did that, right? And so in biochemistry, which was like the hardest class in medical school, we had this really hard teacher. I ended up getting an A in the course because I just studied so much, right? And I wanted to be able to recognize patterns, recognize structures. And I just took that concept and I built upon it as I went through medical school. And in medical school, you have immunology for like 6 weeks or something like that. And I just took it a little seriously. Residency started and I developed more of an interest in immunology. And I knew that I was going to do pulmonary and critical care, but I really loved immunology. So then I did pulmonary critical care fellowship. And then I asked my pulmonary critical care attending, I said, should I go back and do immunology? And then I called Iowa again because I went to KU for a pulmonary critical care fellowship. And I said, hey, Dr. Azar, should I go back and do immunology as a fellowship? Because I really, really love it. And he looked at me and he just said, Jamie, like, you're going to do it either way. You're going to teach yourself what you want to learn. So you might as well there's no reason to waste 2 years. You might as well just go into practice and do it yourself. So I just kind of studied immunology from a pulmonary perspective. And I just built upon that concept. And at the same time, right, when I'm studying immunology and truly learning immunology, I sort of started to see the lack of connection between what we were telling patients to do and what patients understood. And so people kept telling people what to do. You remember when you were a kid, if your mom said to you, hey, go do this, you were like, I'm not going to just go do this, right? You had to sort of figure out a way to, as a parent, to teach your child why they shouldn't do something without telling them not to do it. And so I started to take that approach in medicine. Go ahead.
Yeah, that's the what's in it for me kind of piece.
Yeah, kind of. Like I had to take that approach with medicine. So when I would talk to patients, I would sort of start at that foundation that I had to start with in biochemistry. And I wouldn't say anything about their illness. I would sort of enter the room and I would start teaching them about the foundation of physiology and what normal was. And then I would build on that. And then I would introduce pathophysiology and what they were going through. So much so that like my attending started to ask me and call me to these rooms of patients who look like me, right? Black patients who were having trouble sort of accepting certain therapies. And I remember one particular case, Dr. Simpson was like, hey, we're going to go to this room. There's this Black patient, female, who was being a real bear in terms of therapies, and she was really sick. And I just entered the room and I said, Mama, and I just sat her down and I started to explain heart failure and started to explain the heart, how it normally pumps, explain the lungs, how they work together. And we left the room. She understood. She was calm. She got it. We left the room. We're walking down the hallway, and Dr. Simpson turns to me and he says, how did you know to call her Mama? And I just said, that's what she is, right? She's Mama. That's her culture. I could just tell when I entered the room, right? She's Black, like whatever. Now, you wouldn't call my mom Mama, but her, you would call Mama. So it was just one of those teaching points. And then I just kind of, when I started practicing on my own, I took that concept. And one day I was on the beach with my buddy who was he was kind of a manager, producer, lawyer in Hollywood and entertainment. And he was like, you really know how to answer questions and you speak eloquently. You really ought to start a YouTube channel.
What year is
I was
this?
like, this was in 2016, I think. And I just started the YouTube channel. What's funny is, at the time, everybody's trying to be on YouTube to be a celebrity and come up with viral things and blah, 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 blah. I really just used YouTube to practice my communication because I also started consulting a lot for pharma, consulting a lot for medical education companies, because I just felt like I knew how to break concepts down, especially difficult concepts, interstitial lung disease, asthma, whatever it was. If it had to do with the immune system and it pertained to the lung, like I could break it down. So all of that snowballed. And at first on YouTube, I just ad-libbed it. So if you look at like my first 10 episodes on YouTube, 20 or so, it was ad-lib. It was like, hey, talk about this, talk about that. And I just went because I wanted to understand how my mind naturally talked and naturally put things together. And then I watched it. And then that's when I started to write scripts and started to write like I spoke. And then things just kind of began to snowball. And the YouTube channel became almost like a digital resume. And so all these other companies started asking me to make videos for them. And then that started to compound more. And I got more serious about production, started to take it a little bit more seriously, I suppose, and started to craft educational content in my way, I suppose. And then that led to the podcast, which we've now been doing for a year. Like at 52 weeks, we got 53 episodes out. The 53rd episode came out this week. And it's growing pretty well. We went from 0 to 127,000 subscribers now on YouTube in a year, which is pretty good.
That's pretty damn good.
Yeah.
And we have listeners in over 47 countries. Things have been going well. That's the origin story. And that's kind of how I got here.
Well, Chad, I already got something lined up, but you want to jump in first? I saw you were.
Yeah, no, I'll happily jump in at some point, but we tortured you by keeping you off the board almost 20 minutes in last week's episode, so I feel like I should cede some ground to you,
I will
especially
start. Yeah, I'll
early.
start clawing at the screen if he makes me wait that long.
No,
All
no,
right, so
go for it.
Jamie, okay, you started your YouTube channel 2016 BC, so that was before COVID. So when stuff starts going sideways, and you could argue it was already going sideways. I mean, you and I have talked a bit about this. The our practice was already diving deep in and built out a production studio. We're the recipient of a global attack in 2017. People were already attacking, but it was more fringy back then. And we were already waving flags and saying healthcare providers need to be trained in communication. Can you help us understand one? And I'm assuming, do you still teach at all in your clinical work? And do you teach communication to the people that you are training? And are you aware, do you have any shining examples of programs, residencies, medical schools, where you think that good communication training is taking place for healthcare providers?
So I think the third question, is there a residency program or a program out there that's teaching communication? Well, I'm going to go ahead and say no, because I don't know of it. I haven't heard of
We
it.
don't.
Nor have we. Yep.
I have been asked by pharma to teach communication to many different types of physician groups, and I've done it, right? I just did it recently, a couple of weeks ago, when I was in Boston for Takeda, teaching physicians how to communicate in general, but more specifically, how to communicate alpha-1 antitrypsin deficiency.
Yep.
So yes, I do that all of the time. Now, when you're talking about BC before COVID and all of that, I think the problem with COVID, what happened was that patients, civilians, don't know immunology. They don't know it. They don't know it. And I don't expect them to. And so I had the opportunity to interview Tony Fauci on on one of my shows. And when I interviewed Tony, I asked Tony, he told me to call him that. I said, Tony, I was like, listen, you had 18 months to teach the public immunology. You could have taught them antigen presentation. You could have taught them what your body normally does when a pathogen presents itself to your epithelium. You could have taught them that. You didn't teach them. And I asked him, I said, why didn't you do it? And he looked at me straight in the face and he said, I don't know. I didn't realize that we had communicators that could teach that at that level to civilians. I don't know. And it was a very honest answer. And I think that's where communication breakdown in the vaccine space starts. Is everybody enters the conversation by saying the word vaccine. Everybody does. I don't enter it that way. I teach immunology. I teach infection. I teach what happens under normal circumstances, right? And then I start to teach geometry, right? And what I mean by that is when you look at certain proteins that the immune system likes to recognize, like look at influenza, right? Hemagglutinin and neuraminidase, right? And it's mainly hemagglutinin that your white blood cells, your B cells, plasma cells want to make antibodies towards to neutralize, right? People nowadays have heard of H3N2 subclade K. And everybody's like, oh my God, it's a new virus. No, it's not. It's just different geometry. So the hemagglutinin protein has switched a couple of amino acids. And remember, we're 3 dimensions, right? Proteins in our bodies are 3 dimensions just like we are. And so when you switch those couple of amino acids, it conformationally changes the way that hemagglutinin looks.
Yep.
And so the immune system may not recognize it as well. It doesn't mean it's not going to bind to it in some way, shape, or form. It just means it's not going to be as effective. And so, again, you have to teach that concept. You can't say things like vaccines don't work. You have to explain the immunology of infection for people to understand why vaccines may not be efficacious, or you actually have to explain to people you getting infected. A vaccine is not a force field. You getting infected at home and being in the bed watching TV, that's the vaccine being effective, even if you tested positive for influenza, right? It doesn't mean you don't get infection. It means you don't develop severe disease. And again, what people don't understand, and I think
Right.
most physicians actually don't understand this, is
Though you might
disease.
not get infected. You might not
Yeah.
get infected.
You might not, how do I say this right?
Well,
You might not present to a clinician in which you are tested, but you're not going to prevent influenza from binding to your airway epithelium. That doesn't happen. That's going to continue to happen.
Fair enough. Fair enough.
So what I say to people is disease is actually your immune system's response to a pathogen. That's disease, right? It's how aggressive your immune system, your innate immune system specifically, responds to the presence of that pathogen. And when it happens in something like the lung, which is an end organ, whose responsibility it is to take oxygen from the dirty air that we all breathe and put it in the bloodstream, if you can imagine a virus in that scenario, your immune system has to take up space where the end organ is supposed to do its work. So all of this antigen presentation is taking place in the lung. That's why you're coughing. That's why you're short of breath. That's why you can't breathe. That's why you're in the ICU. You don't want that to take place. Wouldn't you rather just have antigen presentation take place in the local lymph node in the shoulder and then have that communication take place in the lymph system as opposed to your end organ, right? And so I think just explaining that concept to individuals, for me, that's not anything that a human being can argue with. Like, I'm just teaching infection and how it works, right? I'm not teaching so much so get this vaccine or you're going to die.
So again, this is almost Schoolhouse Rock and learning my constitution and bills or how to use contractions. I mean, you're literally taking it down to the base understanding, the fundamental understandings, and building from there.
Yeah, that's exactly what I'm doing.
The issue, and again, what the Trusted Messenger program's about, is you do have like 1950 style, I'm going to recommend a vaccine and you should get it, without having to explain, I think, and getting down to the fundamentals. Like, your strategy sounds like, I'm going to give you fundamentals. I'm going to build up your knowledge base in a way that's relevant to you so that your decision makes sense to you, rather than somebody saying, take this. We're struggling, I think, to get healthcare providers to do exactly what you're doing, which is connect, be relevant, and give good information. And I appreciate you pointing out that you're unaware of a medical school or residency, because so are we. There were a couple glimmers, and they're kind of off the radar. And the funny thing is that we're hearing more and more health systems struggling. Like, what do we do? Our numbers are declining. Whether, pick an immunization, pick a quality metric, and things are getting more expensive, and our staff, there's more turnover. And I think everybody feels disconnected. And I think communication is the glue we need. But Chad, I don't know if the Fauci thing started making you twitch or not, because it was the communication. I'll let him run with it.
Yeah, no, I think that was a great question, and I would have asked him a few more and deeply pointed ones, but I think the bottom line, Jamie, what you got him to admit was that our greatest failure in both healthcare and public health at every single level, local, state, and especially federal, was a failure in communication. I love your tactic of explaining the science and the medicine to people so that they then understand the intervention that you are recommending on top of it. And what is unspoken there, I think, is that you trust the intelligence of the person to whom you are speaking. And I'm sure that you, being a good communicator, I am sure you calibrate some things that you say or don't say, or how you say them, based on what you can discern as the education level or critical thinking level of the patient you're dealing with. But no matter that level, your baseline philosophy here says, I'm going to trust you to understand things that I'm going to explain to you. And that's why Todd laughed at me being triggered. I felt that one of the baseline failures of communication during the pandemic was no one wanted to trust the public, because it was this whole, everybody acted like a sophomore undergraduate who didn't want to admit they didn't know anything for fear of looking like they didn't know anything. And it was just, we're going to kind of stampede sometimes, bullshit other times, our way through the communication of the pandemic rather than taking the time to explain things and trusting that people will accept and understand what we have to tell them.
Yeah, it's really interesting because I think what people are afraid of is, do you remember when John Gruden wrote the emails like 15 years ago and said the N word, I guess, in those emails? And that ended up leading to him getting fired by the Raiders a couple years ago.
Yes.
Emails that he wrote 10 years ago. It's almost like people aren't allowed to change their minds and people aren't allowed to evolve,
Yes.
right? And
Yes.
so one of the things that in society today, and so one of the things I think that people were afraid of is they were afraid of saying, get vaccinated, get vaccinated. And then you get to this point to where you can say, all right, slow down. You probably don't need to. And so when I look at like SARS-CoV-2, we have to understand the virus, right? The virus actually doesn't want to kill you because if the virus kills you, the virus dies. So for me, immunologically speaking, the virus was always going to mutate to become less virulent over time because it wanted to keep you alive so that it could stay alive, right? The virus needs a host to stay alive. So the most important vaccine to receive was the wild type vaccine. When the virus first came out and the immune system was extremely surprised by the presence of this spike protein that overactivated the inflammatory response. So for me, I don't know why you couldn't just teach that and say that and say, hey, listen,
Correct. Amen.
we need the vaccine right now. We need this one. The next one, we may not, but we have to see how things improve over time. This whole get a new vaccine every 3 months, it was a little overkill, I felt, just understanding immunology, right? And understanding, and I just feel like you can listen to the public and their concerns, and you can understand the science, and there is a little bit of a ground where discussion can take place. And the public felt like they weren't allowed to have that discussion.
Yeah.
And that's what we
Yes.
did. We
Amen.
pushed them away.
Yeah. There was absolutely no nuance. Right. And we felt that, nuance might suggest that they not get the vaccine or they, rather than having that kind of thoughtful conversation.
Well, and
You also can't, was one thing that you also can't come out and say, and you sure as hell can't have the president stand at a podium and say, if you get this vaccine, you will not get COVID. They did that, and they did that for months.
And
Complete failure, and utter failure. Because as soon as one person gets the vaccine and gets COVID, oh, they're lying to us. What else are they lying about? As opposed to the very thoughtful, nuanced conversation that you just gave us in roughly the same amount of time, in 20 seconds, talking about wanting to get the vaccine now because of the wild type, because of the way it surprises your immune system, but maybe down the road you won't have to. And also what you said a few minutes ago, which is it's about keeping you out of the hospital and keeping you from dying as opposed to not letting you get sick. These are simple concepts that no one wanted to take the time to communicate.
But Jamie, I'll get back to what we hear from healthcare providers is, so wait a minute, you're telling me you're going to break down immunology. You're going to make it relevant to the patient. Then you're going to explain the intervention that you're recommending and have them go through all that. That's going to take me forever. I got to get to the next patient. I don't have time for that. What's your response to healthcare providers when you were training them and telling them about good communication, when they give you the time factor and say, I got RVUs to generate, they're on top of me, they say, I got to see the next patient?
Don't be stupid. You're smart enough to handle it. Like,
Right.
I mean, a picture is worth 1,000 words, right? I mean, you can describe the function of a virus and its proteins and how a vaccine is functioning in 15 seconds. You can describe how Paxlovid works in 5 seconds. And it's really that simple. Again, for me, I created video so patients could press play and they would already be somewhere
Yes.
when they entered my room, right? So I knew that they were somewhere. They had some level of knowledge. I don't believe that. But I'm also the guy that, again, my clinic is all autoimmune disease, allergic lung disease. Like, I explain immunology every single day. So I recognize that not everybody can do that. It doesn't mean you can't learn that. But I do see a problem with kids today in they memorize a bunch of things coming up. But when it gets down to the foundation, you can get to this point where they just kind of stop. And I just know where their knowledge stops. Right. And I think that we have to do a better job of teaching to medical students that immunology is the foundation pretty much of everything, because it's all about cell communication and receptors and things like that. So I just think that immunology gets thrown in and we just talk about white blood cells and that's it. We don't talk about epithelial cells, endothelial cells, and the receptors that they house, right? We don't talk about that and relate it to the different disease states, myocardial infarctions. Air pollution is the #2 killer worldwide. Air pollution, right? Why? Right? It's immunology, right? And it's the molecules that you inhale. So I just think that like we have to do a better job of explaining that. And if we do a better job of explaining that, then maybe clinicians can do a better job of educating the public. But I am one of those guys that, again, I'm also a guy that doesn't really believe in burnout. Sorry. I'm a guy that just kind of,
Let's
yeah.
put his email back up there,
throwing down.
Chad, so you get the hate mail right now.
Right. I just believe that like you have to diversify your day. If you do the same thing every single day, I got it. Like, yes, you can get sick of it. Right. I mean, if you want to call it burnout, fine, call it that. But if you diversify, what you're doing on a daily basis, which is hard to do, I get it. You won't do that. But anyways, my simple response is like, dude, like it doesn't take that long. Here's a script. Learn how to deliver the script. Move on with your life.
And that's such a great point, Jamie, right? Which is the vast majority of that script is going to be the same for every patient when you are explaining those concepts. Mm-hmm. So once you get that 10-second, 15-second pitch down, you've got it. And you can just bring it out every time and you get better at it and you get faster at it and you fine tune it as people understand it better. And so, yeah, amen. And the second thing I want to say, Todd, I know you want to jump in here. Again, from my communication/educator hat, right? I feel like sometimes there is this notion, and I get it, because it is the public, it is the layperson, to use your term. And I feel like there is this notion of, if we can't explain it to them and teach them in a way that they will be able to remember forever and pass a board exam, or at least take a pop quiz a week from now, there's no point in doing it. But that's such a foolish thought, right? And it's an understandable thought because, we want to educate, we want them to learn, we want them to know this. But you just need them to know it in that moment as the foundation for where you're taking them next, right? Mm-hmm. As long as you can explain it and they understand it in that moment to move on to the next point, that's all the more they need to remember or understand it, and you've already succeeded.
Well, I'm going to jump in and say, we've already pointed out that we can't point to a medical school or a residency where they're doing good communication training. And Jamie, I know you keep bringing everything back down to immunology because you have a passion for it and everything looks probably like a T cell or B cell to you. And it's like, I get it. Everything can be woven through, but I'm sure the gastroenterologist will tell you. At the end of the day, though, I think it comes down to narrative, right? You're weaving in stories, you're making them accessible, but instead, our medical schools make sure that I have hypertension, palpitations, diaphoresis, headache. Yes, that's right. It's a pheochromocytoma with an incidence of 2 to 8 per million that you were asked to study for every board instead of, hey, let me teach you about storytelling. Let me teach you about how to sit down with a patient and connect. Instead, I'm going to have to memorize minutiae, and I don't even need AI for that. I can put that into a good old-fashioned, Google search, and I'll come up with the differential diagnosis that will have pheochromocytoma at the top. But they're not teaching what you're talking about, Jamie. They're not teaching about how to relate, how to read the room, how to look at body language. That's real usable skills that you use on every visit.
I would argue that, just play devil's advocate, that they do indirectly, and this is how. I was a third-year medical student. I'm on a rotation with, I'm on OB-GYN for a couple of weeks. And basically, every single woman we're operating on has like metastatic ovarian cancer, and they end up in the intensive care unit. Remember, I'm in Iowa. So one day, I'm on the rotation, and this lady, Mrs. P, ends up in the ICU after metastatic ovarian cancer surgery, whatever. And I walk into this room and I notice that my ICU attending is busy managing the other 20 patients. The residents and the fellows are doing the same, right? They're kind of all over the place. And so I'm alone with this family, and I'm like, you know what? I'm going to go through things and I'm going to teach this family. Small problem. The family was racist. So I'm in this room and you can feel the tension. When you're black, like, you just know it. And probably Chad does because he's from Philly. But when you enter this room, like, you can feel this racial tension. And I know it's there. And and this is me training myself. I have to have some responsibility. We're fucking adults, right? Like, we have to take on some responsibility as medical students. So I'm in this room and I'm like, all right, dude, you can go ahead and use the excuse of these people are racist and prejudiced and don't want to hear it from you. Or they ain't got nowhere to go anyway. They're going to be right here. So you can just explain. So I just explained. And I went through ovarian cancer. I showed them x-rays. I showed them CT scans. I explained it. And as I was explaining it, I was not only teaching them, I was teaching myself. I understood what worked, what didn't work, what they understood, what they didn't understand. And I'm just taking these mental notes as I'm doing this. This is what rotations offer you. And I do this, and I did this for like 10 straight days. The lady's still in the ICU. I move on to the next rotation. It's over, right? Slow down. Next person comes on the rotation. Mr. P, the kind of patriarch of the family now, says to Kevin, who's on the rotation, he says, hey, Kevin, where's Jamie? He's like, oh, Jamie went to another rotation. And he's like, I never loved a colored fella as much as I love Jamie, but I do, right? And Kevin comes up to me and he races. He tells me the story. And I said to Kevin, I was like, oh, okay, cool. And he's like, dude, I was kind of racist. And I was like, well, was it? Or did I just simply by communicating, simply get him to understand for an entire race of people that, hey, like, we're just like you, we're like, did I get him to eliminate at least some degree of prejudice towards blacks because of the few days that I spent? That's the power of communication. And so I do think that part of medical school is being an adult. You're not going to be spoon-fed all the time. You have to understand that. And I think by simply saying third and fourth year, maybe even first and second year, by simply saying, hey, listen, you're going to go on these rotations. You're going to be relating to people. You need to learn how to storytell. You need to learn how to apply this knowledge that we've handed to you, that we've gifted to you. You got to learn how to explain it to other people. We don't have time to teach you how to explain it. We're not going to spoon feed you everything. There is some responsibility on you, medical student. There's some there. Some. I'm not saying all. I'm saying some. There's some responsibility on you to be able to explain it. Hell, dude, go into Chat GPT and say, how do I explain this to my patient? I don't care. But you're going to learn how to articulate yourself. And again, we're grown-ups. We have to learn. And I think that our predecessors, probably you and Chad, when you guys were rotating, it was different. You were just thrown in. Now we baby everybody. We're so like protective. And I think that like, I don't know, man. I just think some responsibility is on us.
I mean, I'll push back a little bit in the fact that you're being asked to train healthcare providers on how to communicate. The fact that we're being asked to do that same thing. Like every time you described yourself, Jamie, you said, I stopped, I watched how I did it, I got better. I stopped, I took notes, I got better. That's you. That is you driving that. I mean, I understand you took that responsibility very personally, as did our practice, but that's not what we're seeing out there. And I think so many healthcare providers, PAs, NPs, midwives, nurses, docs, are all so overwhelmed by the vast quantity of health factoids you need to learn that I don't think the curriculum is shaped for communication. I think there's the exceptional few that take it upon their shoulders that I need to make myself a better communicator.
They're rushed. PAs and NPs are rushed. That's a major problem with their school. 18 months, and then they can go out and practice. Get out of here. Like, I think that's a little bit fast, right? They're not going to be able to learn all the facts and communicate. Medical school is not rushed. It's on you. Like, medical school is 4 years. The first 2 years, you're basically a college student, and you're studying every day. Most students have zero responsibility. They probably don't have kids yet. They're probably not married yet, right? They just have to take care of themselves. Like, it's on you. Third and fourth year, it's a lot of time. Do you remember fourth year of medical school? I finished fourth year in March. I was done. I wasn't graduating until May, and residency didn't start until July 1st. That's a good 4 months, 3-4 months of just chilling. So if you wanted to insert a communication course or something, you could do it in fourth year. Like, I'm cool with that. But again, most kids that are, I don't know, somewhat adults are going to recognize that and begin to train themselves. But I
But
hear what you're saying.
No,
It's not as
well,
no,
intentional.
wait. I want.
no.
Wait. I'm taking.
I'll
I want first shot at this. The problem is, think of the role modeling. Think of the role modeling the whole time they've been in medical school. I'm going to show you this bulleted, heavy texted slide, and I'm going to talk about each point. They are taught with crappy role models on communication, which is why people come around and they'll be like, those TED Talks are so interesting. Why are those so interesting? I could learn anything during a TED Talk, and they're interesting and they're dynamic. But then my professor goes, okay, point two, 37.6% of, and right, we are taught that communication isn't serious. If it's not serious and boring, it's not important. Like, that was my experience. And
I agree.
frankly, even grand rounds for the most, I mean, you get better
Boring.
talkers, but yeah,
Well, boring.
but boring usually. Like when we
Boring.
go and give a talk, and I know when you give a talk because I've heard you and I've seen the audiences, and they're like, it's like people are like doing the wave. It's like fun. It's engaging. It makes sense. You're showing me video, audio. You're talking to me. You're telling me a story. I don't think that our students get that at any level, including medical students, even though they have time, unless they take it upon themselves.
Yeah. Chad.
Yeah, no, I'm absolutely. Yeah, no, I was. See, I'm getting all fired up because I was going to. Their job in medical school is to teach you the knowledge and the skills that you need to go out and do your job. And I would argue that there is no more important skill that a healthcare provider has than communication. Because if they aren't good at that, their clinical knowledge is basically worth bupkis. Because it's all about communicating and persuading, engaging those patients and getting them to do what you need them to do and understand what you need them to understand. So while I say amen and hallelujah that you're adults and you should work on all of your skills and get better at them, I'm going to say no, med schools have an absolute responsibility at which they are failing miserably right now in equipping healthcare providers with the skill sets that they need to do their jobs most effectively. I would also say, as someone who for a very long time has taught communication, there are people like you and Jamie, I would have friggin' loved to have you in class, because it's clear that you're a natural and it's clear you're someone who's attuned and is constantly doing that, working on it, fine-tuning it. You get it. There are lots of people who don't get it the way you do, right?
It's not fair. It's not fair to say that I get it because I wasn't like this in medical school. But go ahead.
Well, you get it now, and you have gotten there. And I would say you could have been further along much sooner had you been taught it by someone who is good at it. As when we talk about skills and teaching skills, there are only two ways to get better at a skill. One is to do it and keep doing it as you get better, and the other is to be tutored or mentored or coached by someone who does it better than you and or has more experience than you and helps that process along of you doing it. And so it's clear you have innate talent and innate interest in it, but that could have been sparked much easier. That said, there are lots of people out there who don't have that innate talent and don't have that innate interest. I would always tell people, I can make anybody, give me anybody in my classroom. I can make them a good, solid, competent communicator. I can't make them great. I can't make them amazing. That has to be a combination of good teaching and raw talent. But I can at least make them good and solid, competent professional communicator at the very least. And I'm sure Todd agrees with me on this. At the very least, medical schools, PA schools, MP programs need to be at the very least, minimum, just at the floor, teaching people to be good, solid communicators. And then I would say, agree with you completely. After that, now it's on your own. Now go keep building on that foundation.
You have to put yourselves in those scenarios. What I didn't mention in my origin story is that I ended up tutoring biochemistry starting like right after that semester. So that's the beginning, right? And so again, I can't sit here and say that I was like this in med school. I had 10 years to get this way. I had 4 years of med school, 3 years of residency, 3 years of fellowship. I had failed time and time again at things. I remember an ID professor calling me into his office one day, Dr. Nassif from Iowa, and I was like a intern or a second year resident, I can't remember which. And he's like, "Are you interested in your evaluation?" And I knew I had sucked on the rotation. And I was like, "No, I'm not interested." And he was like, "Come into my office." I was like, "Fine." So I go into the office, and this professor, Dr. Nassif, studies neutrophils. And we're just talking. And, I was being so stupid. And for some reason, I started talking about like single mom and my dad did drugs. And he looked at me dead in my face and he was like, "Yeah, I'm not interested. You sucked. You need to be better. And this is how you need to be better." But you have to put yourself in those situations. And I feel like nowadays, every single kid, including my own children, and probably yours, is afraid of failing. They're afraid of failure. They're afraid of it. They want to be great at everything. And if they're not great at it, then they just simply don't do it, right? And so that's the problem, is you've got this group of kids that's just not communicating. They're just not doing it. So I guess what you guys are suggesting and what you're saying is how you would do things differently is you would force them to be in those scenarios in which they have to communicate. And
yes,
I don't disagree with that. I'm just saying that, like, I was forced. I remember, oh my God, I was lucky. I think I was just lucky. I had I was on oncology rotation. I think I was third. I might have been fourth year med student on oncology. And Dr. Milhem, who is a sarcoma specialist at University of Iowa, we looked at this MRI. There was cancer, melanoma all over the brain. This lady didn't know, right? She had undergone therapy before. And he was like, "Go in there and tell that lady she has cancer in her brain." And I was like, "What?" He was like, "Go in there." And he had this very characteristic snap. He would be like, "Go in there. Tell her she has cancer on her brain, Jamie." And I was like, "Fuck it. All right." So like I go in there and I said, and I don't remember her last name, but I was like, "Mrs. Smith." And she's like, "I have cancer in my brain." The one thing Milhem said to me was, he's like, "She knows. Trust me. She knows." Right? Because it was huge. And I just go in there and I was like, "Mrs. Smith, you have," and she was like, "I have cancer in my brain." And I was like, "Yeah." And she's like, "So what are we going to do?" And I started to explain, and I pulled up the MRI. And then Dr. Milhem kind of walked in to give me the communicating support I needed right at the right moment. I was lucky. I had teachers like that along the way.
Yeah.
I just got, or I just paid attention to those teachers, and I paid attention to
both.
those cues. Or both, right?
Yeah.
So I was really, really, really lucky. But you're right. It does need to take place because a lot of this, I do a lot of asthma in my clinic, right? And I'm an adult physician by training, but I started seeing pediatric asthma maybe 6-7 years ago because pediatric asthma in my area is so piss poorly managed. And I think part of it is because of the lack of understanding of what asthma actually is. And what I noticed was no one knew what asthma actually was, even though these parents had had children with asthma for 7 years, 10 years. They had no idea what it was. They had no idea what the inhalers were for. They had no idea, the guidelines had changed in terms of inhaler management and adding budesonide. And so again, and I guess that's from lack of knowledge of clinicians, but also lack of communication. Or maybe the clinicians did tell them, and the parent just didn't hear it because they used the wrong term. I don't know.
Yep.
But it wasn't in a way relevant enough that their kid with 7 years into it is still not understanding the basics that you then make it relevant to them, which then makes them understand. Oh, so that albuterol, my beta agonist, that's not good for really controlling the big picture. Like, I mean, until they get like you said, like you made it relevant. Then it's a story that I can, it's not a factoid. Like, which one am I using again today?
One more story. I got to tell this story because I love this story. I was it was like my first year out of practice, and I wanted to talk on interstitial lung disease, right? Because it's like immunology of the lung, understanding fibrosis, epithelial mesenchymal transition, all that junk. And I go to this lecture by Paul Noble, who was speaking on behalf of Genentech on the drug Esbriet pirfenidone, which is an antifibrotic for IPF, idiopathic pulmonary fibrosis. I go to this lecture. I bring my 3-year-old daughter with me at the time, and everybody's mad because I brought a kid. And I'm like, "Dude, she doesn't understand what you're saying. Just put the iPad on, whatever." So we go. Anyway, I leave the talk, and I'm like, "You know what? I can do that." So I end up going to Chest that year, and it was in Los Angeles that year. I go to Chest, and I had a couple beers, all right? And I'm at dinner with like the Genentech executives, and we start talking pulmonary fibrosis. And I get the bar napkin, And I start drawing out the cells and the mechanism, pulmonary fibrosis. The next day, I got an email saying, hey, you're going to come to speakers training in Arizona. So I go to speakers training in Phoenix. And when I go to this speakers training, you guys, like seriously, like everybody who had wrote every single paper on pulmonary fibrosis was at the speakers training. Okay. Everybody, like all the godfathers of idiopathic pulmonary fibrosis, the smartest guys on the planet, right? There's like 30 of us there. I'm the youngest one. I'm the blackest one, right? I go to this thing and then I'm in this room and Dr. Oh my God, who was it? It was Steve Nathan is there. And so Steve Nathan teaches us this deck, okay? Goes through all 32 slides. And then they come up and they're like, all right, you guys, now each of you are going to give 7 to 10 slides of the deck, right? All 30 of us. And you're just going to teach it in the way in which you would teach it. And, you know, they poured wine at the tables. And they're like, Jamie, you're going first. And I'm like, are you, dude, you got the godfathers of pulmonary fibrosis, and they're all sitting here. And they, you know, like, come on, like ask them. Like, why do I have to go first, right? So I was like, fuck it. And I just like chugged my glass of wine and I just went up there. And have you ever seen the movie Old School with Will Ferrell?
Yes.
Old School movie. So there's this debate show where he was debating James, whatever, the big famous Democrat. And he just kind of shouted out this stuff. And he was like, what happened? I don't know. I blacked out, right? So I go up there and I give the first 7 to 10 slides in my way. And I knew the material, right? I had studied the immunology and I gave it in my way, whatever. And I'm stepping off the stage and Dr. Nathan, and this is kind of like my welcome moment, right? And I get emotional when I talk about it. But Dr. Nathan, he says, young man, and he grabs my hand. That was the most outstanding way of describing pulmonary fibrosis immunologically. You are a great speaker and probably a fantastic clinician. And I just sat down and I was like, okay, I guess I can do this. Fast forward 9 years later, 8 years later, I work with Dr. Nathan all the time. We always talk together. And he taps me on the shoulder. And I'm not very loud. I've only recently become loud about my podcast and YouTube and stuff. But he taps me on the shoulder. He says, you know, Jamie, my wife is a huge fan of your YouTube channel, right? And it was just it's just one of those things where it's just one of those moments when you just put yourself in those moments to fail. You put yourself in those moments to learn something new and to be challenged. There is success there. There's success in putting yourself there. And there's success on the other side when people recognize that. And I really feel like we as a society, we recognize failure very well. We talk about it out loud. And we're like, you suck, or that's no good, or I can't believe you did that. But like, we rarely are like, congratulations, like you did such an awesome job. And I think maybe I had more moments like that allowed me to get to where I am. I don't know.
That's a fantastic story, and I think there's also a lesson there that I want to point out to folks. And it goes back to Todd, to your earlier imitation of the bullet points and the teaching. You actually got that slightly wrong because you were looking at your audience when you were speaking. In reality, it would have been head down reading from notes, referencing things over their shoulder. One of the other lessons there, Jamie, couldn't agree with you more, is the notion of authenticity and of standing up and communicating, whether that's on stage in an academic conference, whether that's in an exam room, in a way that you are naturally disposed to do. One of the things I used to tell my students all the time, including Todd, when he was my student, I'd say, I need more Todd. Give me less stereotypical pediatrician. Give me less stereotypical academic speaker. Give me more Todd, and people are going to respond to that. And it takes a lot of balls to stand up at an event like that and go first and be like, you know what, I'm the kid in the room, but I'm just going to be me and let the chips fall where they may. And people are responding to it because you're engaging them in a natural and authentic way.
And Jamie, I know we're getting to time with you, but I just want to say your message about making the points relevant for the people that you're talking to down to the base unit. And as you said, using immunology as your pathway into really explaining everything. I also hear your point about medical students and healthcare professionals needing to take a little more ownership and being a little more resilient and being willing to take risks and also taking it upon themselves to be better at what they do. I hope that the people that help shape these healthcare providers take it on themselves to be better teachers and to weave in more communication.
Sure.
But I would love for you to kind of wind up like just what do you think needs to be done here to really, with everybody competing for people's attention now, what do you think healthcare providers, knowing we still have trust, need to do, or what advice do you have?
Healthcare providers need to sort of, again, I mean, the cliche thing would be to say they need to communicate better. Obviously, they need to communicate better. But I do think that healthcare providers need to put their foot down a little bit, and they need to be able to communicate in a way that is evidence-based from a science perspective and say, this is how science works. But they also have to be open-eared to listen to their patient.
Yeah.
In a way
Amen.
where you can sort of combine what you're both saying into a reasonable therapeutic strategy. Sure, yes, you do need to be on this statin, but you would like to stay away from it and try to exercise. Cool. I'm going to give you 4 weeks to lose some weight. We'll check your numbers. We'll see what happens. If it doesn't go down by this amount, why don't we try the statin at this dose? Does that sound reasonable to you? Right. So I do think that there is sort of a combination of things, right? That's what I've had to do, right? Looking at all these peptides and stuff that people are like taking, like, sure, the mechanism makes sense. And if you can afford it and you want to do it, and I know that it's not going to harm you because of the mechanism, go ahead, fine. But this doesn't replace medical strategy, right? In terms of managing whatever it is we're trying to manage. But I get it, because there's that gray area, right? There's that gray area where patients are still suffering and the medications aren't helping that suffering. And so patients are still exploring. And that's where the supplement industry and the peptide industry is sort of taking advantage of people. And I do mean take advantage of people. So like that, but I do think that, clinicians need to learn about those things and apply some of those mechanisms and see what the supplement industry is trying to do. But again, say things like, no, dude, there's no detox. Your liver detoxes, your kidneys detox, your immune system detoxes. Like, listen, these are the enzymes that are involved. Just make sure you eat these vegetables and these fruits to allow your organs to work as efficiently as possible. You don't need to go take, blue hedge juice, like whatever. Like, so again, you just have to be able to have that conversation. I don't know.
Love that. Two real quick hits. You've already mentioned lots of mentors, teachers, professors in your life. But one of the things we've been doing is asking every single person who comes on the show now, give us a shout out to one particularly, just a brief shout out to a particularly impactful teacher, educator, mentor in your career.
I had so many mentors in my career. God, this is a hard question, you guys. Because it's like
you can come back on another time for another mentor, but you got to pick one for this one.
The mentor that really stands out to me is probably Mohammed Milhem from Iowa, who put me in that situation of telling the patient that she had cancer in her brain.
Yep. Okay. And last question. We talked about this before we went in the air. I said we have to talk about it when we're recording. This episode drops on Friday. 2 days later, your football team is playing my football team in a playoff game. Give me a predicted final score.
If the game goes in which Philadelphia's offense is playing up to their potential, the 49ers lose that game. But I do think it's closer than people might think. I think it's 27-24. However, if the Philadelphia offense plays how it's been playing, this could very easily be a 20-17 49er victory. So,
Chad, what's your prediction?
I realize now that we made a mistake. We should have just talked about this game for the last hour, because as great as the last hour was, I'd love to do a breakdown with Jamie, because, man, he gets it about his team and my team. He understands. To me, this is really interesting because I totally agree with literally every word he said. I think it could go either way, but I think the Eagles defense and the Eagles struggles on offense both keep this a low-scoring game. I don't think either team's going to get higher than 20. So I'm going to go 2017 one way or the other. I'm obviously hoping it's the Eagles, but I could easily see, as you said, that's literally the score in my head, 20-17 49ers also. We will find out in a few days.
Jamie, thank you.
Good luck to the 49ers.
Yeah, thank you so much for joining us today. I'll let Chad take us out, but thank you so much for
no, absolutely fabulous. Something tells me, and this has been a recurring theme lately, Todd, we pick good guests, messengers on this show. Something tells me we'll have Jamie back again. Dr. Jamie Rutland, thank you so much for being a guest on the Trusted Messenger podcast, where we are spending this fabulous time each week talking about why and how good communication is essential to good healthcare, and how healthcare providers can get better at both. We will see you next week. Thanks.
Thanks, guys.